Good evening, all our esteemed members of Maharashtra Ophthalmological Society, especially from hello, yeah, our young friends and our young stars who are joining us from the nooks and corners of Maharashtra and beyond. All our postgraduates for whom this webinar has been specially curated. We all know that Maharashtra Ophthalmological Society is one of the biggest state societies in India. Activities time. Every month is dedicated to one specialty, and this month has been dedicated to oculoplastics. We all know that we all have to present a short and a long case in variety of specialties, and today we are going to go through how a ptosis and a proptosis has to be presented, what are the common questions asked, and our panelists and the mentors are going to take you through to make sure that you learn a lot today. So first of all, we would like to thank our mentors of today, Dr. Naina Poddar ma'am, Dr. Shruti Shirvatkar, both from Sayana Hospital, and Dr. Naina Poddar ma'am from Nayar Hospital. We are very lucky to have a great set of panelists. First of all, Dr. Maya Hada, who is joining us from Jaipur. She is an associate professor from SMS Medical College, and Dr. Vidya Shankar sir, who is joining us from Maharashtra as MOS faculty. This session is going to be moderated by Dr. Neerav Raichura from Mumbai. And we are from Team MOS to Dr. Sumit Lahane, who has been instrumental in coordinating this monthly PG programs very, very meticulously. So without further ado, I would like to now invite our President, Honorable Dr. Santosh Agarwal, sir, to please give his welcome address. Over to you, sir.
Thank you, Dr. Vardhaman. Respected teachers, seniors, my dear friends and postgraduates. Very good evening and welcome to this distinguished PG Grand Round. At the outset, I thank Dr. Naina, Dr. Shruti, Dr. Maya, Dr. Vidyashankar for sparing their valuable time for this PG teaching program. I extend my best wishes to Dr. Nuvera and Dr. Arya for their case presentation today. I humbly appeal all PGs to please attend and also present cases in these webinars because it will help them in their final exam or in the practical exam, and it will boost their confidence as well. I am sure we would have a great discussion today which will enlighten us in regards to nuances and intricacies of these cases. I also request our PGs to ask your queries, questions to our experts through chat box or directly send to Dr. Sumit Lahane. I also express my gratitude towards my MOS team, especially Dr. Sumit Lahane, Dr. Vardhaman, Dr. Aditi for their immense contribution in crafting this PG training webinar. I also thank Entod for the great technical support. Thank you everyone. And my today's quote is in Marathi actually. I will also convert it in English. प्रतिभा प्रत्येक व्यक्तीत असते, पण क्षमता कठोर परिश्रम केल्यानेच येते. Everyone carries unique talent. However, you can excel by your hard work only. So do your hard work and excel in your exams. Thank you very much.
Thank you very much, sir. And I think, of course, I think there is no substitute to hard work, as you have rightly said. I'm sure all our residents will put in a lot of hard work for their preparations of not only exams, but in also their further life. Thank you very much. So, friends, as the chairperson of the scientific committee, I'm extremely happy and very thankful to Dr. Sumit Lahane for coordinating everything. And before I hand over to him, I would like to make a small announcement that is on the coming weekend on the 4th and 5th of May. As we know that MOS is planning this very unique midterm virtual conference for our young ophthalmologist, which is called as the MOSCON Midterm Young Turks. So all of you are invited to attend, which is the only platform right now all over India, which is by a state society, where 100% of the speakers and 50% of the panel is going to be young stars who are less than 40 years of age. So we all look forward to welcome you there also at MOSCON Young Turks. And now over to Dr. Sumit for the further discourse of today's evening webinar. Thank you.
Thank you, Vardhaman sir, and thank you everyone. Especially thanks to MOS, Santosh sir, Atul sir, Vardhaman sir, and Aditi ma'am for encouraging all the PGs all over Maharashtra, including all the colleges, to participate in this program and having a subspecialty wise. So we are covering all the specialties. And this month our specialty is oculoplasty. Of course, it is close to my heart because it's my own subspecialty. And my dear friend Dr. Neera will be moderating the whole show. So I will just hand it over to Nirav for the introduction, and Dr. Arya will be presenting first. I will begin with the Nirav now. Nirav, you need to unmute.
Thank you so much, Sumit, for making me a part of this. So postgraduate programs have become an integral part of MOS, and the efforts of MOS in this direction are really praiseworthy. For today's session, we have two postgraduate students, Dr. Nuwaira Mustafa and Dr. Arya Mall. Dr. Nuwaira Mustafa is a Mumbai. The session mentors for today are Dr. Naina Poddar ma'am and Dr. Shruti Shirwadkar. Dr. Naina Poddar ma'am is the head of the Department of Ophthalmology at Nair Hospital, Mumbai, and has been the unit head at Sion Hospital in the past. Madam is very actively involved in all PG teaching activities and has been a guide and mentor to hundreds of students. Dr. Shruti Shirwadkar ma'am is associate professor at Sion Hospital, Mumbai. Madam is known to be very approachable and student friendly and has imparted knowledge and wisdom to hundreds of PGs. The panelists for today are Dr. Maya Hada and Dr. Vidya Shankar. Dr. Maya Hada is currently Associate Professor and in charge of Oculoplastics and Ocular Oncology Services at SMS Hospital, Jaipur. She's done her MD Ophthalmology with gold medal from RP Center AIMS and has completed her senior residency as well from AIMS. She has several awards and accolades to her credit. Dr. Vidya Shankar sir is one of the senior most oculoplasty surgeons in the city of Mumbai. And all of us, including me, from him. He has the distinguished credit of being an optometrist. An alumni from Shankar Netralaya, he has been a mentor to several oculoplasty fellows himself and has been credited with establishing and developing the oculoplasty services at Bachwali Hospital, Mumbai. I now request the PGs to start the session. Dr. Arya, you would be taking the first case, right? Arya, you can unmute yourself.
Yes, sir.
Yeah, please go ahead with the presentation.
Good evening, everyone. Good evening, everyone. Myself, I am Dr. Arya Molvias. I am junior resident from LTMMC NGH Sion Hospital. Today, I will be presenting a case of management of unilateral congenital ptosis in a 3-year-old male. It's a case of a 3-year-old male child, resident of Dharavi, brought by and informed by mother, presented to the OPD with complaints of drooping of left eye upper lid since birth. There was no history of alteration of eyelid position with feeding. There was no history of ocular deviation or swelling in affected eye. No history of diurnal variation or history of similar complaints in the other eye. The child has a full-term normal vaginal delivery by birth with no history of associated birth trauma. All the developmental milestones were established up to age. No history of systemic illness or any recent infections. The child was immunized up to age. Family history, there was no history of squint or ptosis among family members. The general examination and the systemic examination findings were within normal limits. Ocular examination, the child fixed and follows object with no fixation preference. No significant astigmatism was noted in retinoscopy. Head posture, no head tilt or chin lift was noted. No facial asymmetry or nasolabial fold asymmetry. Eyelid skin condition was bilaterally normal. On examination, the anterior segment examination, left eye had ptosis. Other than that, the rest of the anterior segment examination findings were within normal limits. The conjunctiva, cornea, and anterior chamber were normal. Pupil was normal size and reacting to light in both eyes, and the lens was clear. And the fundus examination was also within normal limits in both eyes. Coming to the ptosis evaluation, the right eye was within normal limits with a palpebral aperture height of 10 mm. MRD1 and MRD2 were 4 mm and 6 mm respectively. With a good LPS action, Bell's phenomenon was good and Marcus Gunn jaw winking phenomenon was absent. Upper lid crease was 7 mm and the eye pack test was negative. Corneal sensation were intact and EOMs were within full and free in all direction. Coming to the left eye, the palpebral aperture height was 5 mm in primary gaze and a lid lag was noted in down gaze. MRD1 was -1 mm and MRD2 was 6 mm. LPS action was poor excursion with less than 4 mm. Child had good Bell's phenomenon with absent Marcus Gunn jaw winking phenomenon. Upper lid crease was faintly seen. Eye pack test was negative and the corneal sensations were intact. EOMS was full and free in all directions. My provisional diagnosis is right eye within normal limits, left eye congenital ptosis with poor levator function. The child was investigated for systemic investigations were done and the anesthesia workup also was done. The routine blood investigations were within normal limits. Child was non-reactive, serology was non-reactive and the chest x-ray was within normal limits. The child was posted frontalis flap advancement procedure under general anesthesia. Lid crease incision was marked and an incision was made using a 15 number blade. The dissection was carried out to the anterior tarsal plate using a Westcott scissor and this was carried out superiorly above the superior orbital rim around 5 mm. And the frontalis muscle was identified which was separated and a flap was created. The muscle flap was brought anteriorly and was sutured to the anterior 1/3, the superior 1/3 of the tarsal plate using 3 horizontal mattress suture using 60 prolene. The lid crease was made and the skin closure was done. This is a pre-op photo of the child and the second one is a post-op image of the child where lid edema was noted. Whereas in day 20, the correction, however, the ptosis correction is noted. Thank you.
Thank you, Dr. Arya, for the to-the-point presentation. I now invite the mentors, Dr. Naina Poddar ma'am, to assess the PG and ask further questions.
So Naina ma'am has a poor internet connection, Dr. Nirav. So Dr. Shruti ma'am, if you don't mind, continue with the question for both the PGs, please. Dr. Shruti ma'am. Nirav, meanwhile, you can start asking questions. I will contact Shruti ma'am.
Yeah, I think Dr. Shruti is trying to speak, but it is muted.
Yeah. Now I think,
Hello?
Can you hear me now?
Yes, ma'am. Yes.
Yeah. So, Arya, nice presentation.
Thank you.
So I would like to ask you that what is the classification of ptosis based on etiology?
Ma'am, ptosis can be classified as clinical and acquired and congenital ptosis. However, when coming to the etiology, it is divided into a neurologic ptosis, myogenic ptosis, aponeurotic ptosis, and this mechanical ptosis. Myogenic ptosis is generally seen in the case of a condition which affects the elevators of the eye. Most commonly in the case of a myasthenia gravis or a myotonic dystrophy, or in the case of a CPEO. And the neurogenic ptosis is commonly seen in association with Turner palsy, or in the case of a Horner's syndrome or Marcus Gunn, any other cases of synkinetic ptosis. And in the case of aponeurotic ptosis is most commonly associated with a senile changes or an involutional ptosis. And then we will have a mechanical ptosis, which is seen in the case of a tumor or a mass which affects and which results in ptosis.
Right. So you have described it very well. But in short, can you just enumerate the points by which on clinical examination you can differentiate between a acquired and a congenital ptosis?
Ma'am, in both ptosis, there will be like a mild to severe grade of ptosis will be present. However, in a congenital ptosis, lid crease formation won't be there. Like lid crease will be faint or absent, and in and also the LPS function. The LPS function will be either fair or poor, mostly poor in the case, because most commonly it will be associated with the dysgenesis of the LPS muscle. So it will be poor function of this and associated with a lid lag, because the LPS muscle will neither contract or relax on downward gaze also. So a lid lag will be noted in the case of a congenital ptosis, whereas it won't be seen in a keratosis.
Right, very good. And generally ptosis can be associated with other syndromes. So what are the synkinetic, or what is the synkinetic ptosis and what are its causes?
Ma'am, synkinetic ptosis is most commonly seen in association with Marcus gun jaw winging ptosis, where there is an aberrant connection between the mandibular division of this trigeminal nerve and this oculomotor nerve. And like this happens when the patient, when there is a chewing of the ipsilateral side of the lateral pterygoid muscle will be affected mostly. There will be retraction of the ptotic eye will be noted. And the other thing is like an oculomotor, other synkinetic syndrome will also be seen, like any other causes, like a CNS causes of trauma or tumor, or results in an abnormal synkinetic aberration of the third nerve, which itself can result in a synkinetic ptosis.
Okay. So, and suppose the ptosis, if it is like associated with the myasthenia gravis, what are the most important tests, the most 3 important tests you would advise to the patient?
Ma'am, clinically, we will do a ice pack test. There, like an ice pack will be placed over the ptotic upper lid, and then we will observe for the improvement of the ptosis, which is considered to be a positive test. And like in 2 minutes, it is 2 to 5 minutes of time will be given, and improvement will be noted. The other thing is the fatigability test can be done, where the patient is asked to look upper, look upper side, and then there will be an drooping of the eyelid will be noted because of the fatigability of the LPS muscle. And then the other test can be a Cogan lid twitch will be noted when the patient will, from the down gaze, when the patient look on the up gaze, there will be a twitching or a retraction will be noted.
Nirav?
Yes, Suman.
I think if the mentor's questions are over, you can go ahead with the panel.
Correct. Yeah. So I now invite the panel for discussion. I invite Dr. Maya Hada and Dr. Vidya Shankar. Ma'am and sir, would you like to add something or suggest something to the PG for the presentation?
Yeah, very well presented case, Arya. I congratulate Arya and her mentors for such nice presentation and such nice surgery. And one thing that I would like to add is one thing in your diagnosis, you mentioned left eye congenital ptosis with poor levator function. So you should always add whether it is simple or complicated. So in your case, there was no Marcus gun, no synkinesis or BPS, nothing complicated association. So it is a simple congenital ptosis, and you can also add the severity. So simple congenital severe ptosis with poor levator function, and to complete, you can also add with good Bell's phenomenon. So that will make a complete diagnosis for a long case presentation, right?
Okay. Okay.
Other thing is that you mentioned the visual acuity is equal in both the eyes. So in your case, the patient was not having any abnormal head posture. There was no chin up position, and the severity was like it was obscuring the visual axis. So usually in such cases, do you expect optimal vision or subnormal vision in such children? And what is the cause of suboptimal vision, if at all?
Ma'am, in this case, the child had a moderate to severe ptosis actually. And usually in the case of a severe ptosis, there will be a chin up position will be there. And in these cases, amblyopia can be expected in the child in the like in the future. So if in suspicion of this amblyopia, the surgical correction can be opted for children. Like mostly we advise a surgery like more than 3 years of age. Like less than 2 years of age, we won't advise a surgery. But less than 3 years of a child, 3 years of age with a case of moderate to severe ptosis, surgical correction can be done in child. In like we most commonly we expect the child might have a amblyopia.
Right. So well said. There may be an amblyopia. And what is the reason for amblyopia in such cases? Mostly.
What are the types of amblyopia, you know?
Ma'am, in this case,
the visual axis, if it is obscured, then it can be form vision deprivation. But more
yeah,
common,
deprivational amblyopia can be most commonly seen because of
yeah, but more commonly it is refractive, like an isometropic amblyopia because of the astigmatism or any kind of refractive error. Okay.
yes, ma'am.
All right.
Ma'am, just for the advantage of the audience, just for their benefit and for the PGs, a few more questions that I would like the panel to answer. One is how early, in terms of age, would you operate a case of congenital ptosis? And whether in a very young age, would you prefer silicone sling or a frontalis flap?
All right. So as she mentioned already, Arya mentioned that if it is a severe ptosis, it's amblyopigenic. So we can operate as early as possible. If the visual axis is obscured, then as soon as the patient is fit for GA, I think after 6 months, we can operate. I have operated upon 1-year-old child for severe congenital ptosis. That is the earliest that I have operated. Otherwise, I would like to wait for at least 3 years of age. And because the post-op care is very crucial in such patients. So otherwise, I would like to wait till 3 years of age. The other question was between the frontalis flap surgery or silicone sling. So it is the surgeon's preference that whichever method he or she is comfortable with. In my hands, I am very much comfortable with silicone sling, but in this case, there was very good post-op result that was shown with frontalis flap also. I have tried frontalis flap in adult patient, and in Marcus Gunn phenomena after LPS excision, I've done frontalis flap. But in children, I am yet to do a frontalis flap surgery, and perhaps after looking at the result at this case, I'm very much motivated. Yeah.
Thank you, ma'am. Dr. Vidyashankar, sir, would you like to add something?
Yeah, I'd like to add one particular thing. One thing that was missed in the during the diagnosis is you need to even check on the tear height, tear meniscus, and the tear. Basically, that is one of the protective things. And then if you are going to be seeing a patient with dry eyes, then you would need to explain to the patient preoperatively that the patient will have to be on lifelong lubricant. Okay. And that makes it worse if there is going to be a bad or an inverse bells. So that's something that you would need to counsel the patient before going in for surgery. I didn't see that tear thing put up on the, you might have done it, but it was not there.
yes,
The second thing is you can go ahead, as madam said, that you can go up to 6 months of age, you can go for surgery. And the way to cut short on the time for surgery, basic thing is that the child should be fit enough for surgery. And in that point of time, just one stitch in the center of the lid should be sufficient rather than going for 2 points and things like that. Because anyway, the tarsus is going to be extremely thin in such children. Yeah. So this the tier thing is something which I thought that has to be mentioned. They will ask for it during your exams. This is basically for students. Yeah. Otherwise, I think she has completely mentioned all the requirements as far as a student is concerned. Good. Keep it up.
Thank you, sir.
Thank you, sir. So the other question is that the confusion with synkinetic ptosis, like what are the options and what is your preferred practice in terms of treatment of a correction of a synkinetic ptosis?
See, synkinetic ptosis, where I'm going to be seeing a Marcus gun, is something which I will operate only if I'm going to be told by the parents that it does not look good enough. Because the child will keep the lid proper positioned in course of time. And as we know, the child will outgrow the synkinesis in most of the times, and the synkinesis will reduce with age. So there's no point, according to me, to chop off the LPS, and because synkinesis will come back again, however meticulous and you try and dissect the LPS, it is some amount of it is going to be there. So then you are going to be facing the parents who's going to come back to you and say that you said everything will go, but even now the child is winking. So synkinesis, so you handle it if the child is becoming conscious. You tell the parents not to make the child conscious in the first place. And if the child does get conscious, then that's when you would want to do an LPS with a frontalis or a frontalis advancement or a sling.
Right. Thank you, sir. Dr. Maya, would you like to add something, or is your practice pattern different, or is the same?
Yeah, I very much agree with Dr. Vidya Shankar that if it is a mild wink or mild flutter, then they tend to adapt with age. They adapt some, they tend to do some jaw clenching and it does get reduced. So if it's cosmetically insignificant, then we need not to worry about it. But sometimes the Marcus gun is very severe, like 5 mm, it's going and its scleral show is there. Then of course the child is conscious about it. And then in adult age group, like after teenage, they very much become conscious about it, and then we can operate perhaps. And I would go for levator excision and bilateral sling in such cases to achieve symmetry. Yeah, it's difficult to completely excise the aponeurosis. Some fibers may remain attached, but it does dampen the Marcus gun to very much extent so that it does not remain cosmetically significant. So it does help in improving the cosmesis.
So ma'am, you would be doing bilateral excision of LPS?
No. LPS excision on the affected side.
On the affected side. Bilateral sling for the symmetry.
For the symmetry, yeah.
Okay, thank you, ma'am. So now this brings us to the next question is, what do we do in a case of ptosis with poor Bell's phenomenon? What are the options that we have, and what is your preferred practice?
This is for me. Yeah.
For both the panelists, yeah. Yes.
So ptosis with the poor Bell's phenomena are mostly like myogenic ptosis, like CPO, like other things. And I usually advise them crutch glasses, and because it's a progressive condition. And sometimes when I have to operate, then I just do an optimal correction so that the visual axis gets cleared, and we don't want to give them a cosmetically good result and leave the lid margin near limbus, because we know that the Bell's is poor and it will lead to exposure keratopathy. And then definitely we would like to put a frost suture for a longer time and give copious lubricants and wash them closely. So not do an optimal, but just an adequate correction to clear the visual axis.
So, ma'am, in these cases, especially CPO that you mentioned, you would be doing a sling or under correction with an LPS resection?
No, I don't never do LPS surgery in these cases.
Sling in all these cases, right? Yeah. So, your inputs, please. On
I would agree with Dr. Maya in this. The only thing is when you are, and nowadays you have got very good crutch glasses with a hard silicone and things like that. Previously, it used to be a metal crutch. So that used to cause a lot of atrophy to the skin and the muscle. So but nowadays you get much better material over there. So fresh glasses would be, and just a suboptimal this frontalis sling. I would not go in for an advancement and things like that. Sling is something that you can always reverse it. It's much easier to reverse. And in CPO and such things, you do require to sometimes go back inside and correct it further and things like that. So in such cases, I would do only a sling.
Right. Thank you, sir. Now the last question on Ptosis. When do we reoperate in cases where the sling is migrated or given way from certain, from say the eyelid side, or so? How do we decide, and how early can we do a secondary surgery in these cases?
We can go ahead and do a early surgery in these also, but many people are tempted to keep the previous sling in place and go ahead and put another sling. That is not, because I have seen patients, because sling surgery is something which is easily done by many people. So लेकिन वो sling निकालना है, that becomes a horrendous thing. Go in and search for it, but that should always be part of the surgery, that the previous sling should be. See, we can convince ourselves that they are silicone, they are not going to irritate, they are not going to cause problems. But you have a sling inside, that means that 1 or 2 points of traction is going to be there. So the final outcome of the lid contour may not be what you can justify to the patient. So the previous sling comes off and you put in a fresh one. And definitely so if the sleeve or the sling is infected.
Thank you, sir. Ma'am, would you like to add something?
Yeah, first of all, we should take a good bite from the, pretarsal tissue so that it does not get slipped off or it does not get migrated. And I've not seen many cases of sling migration, but if at all it does migrates or slips from its attachment at the pretarsal tissue, we need to operate as soon as possible. We need to take that sling out and redo the surgery from new sling. Yeah.
Thank you, ma'am. So now I request the second postgraduate student today, Dr. Nuwaira Mustafa, to go ahead with her presentation. Dr. Nuwaira, can you please share your screen? Yeah.
Yes, sir. I'm sharing. Yes. I am Dr. Nuwaira Mustafa, junior resident at Nayar Hospital. I am very grateful to all MOS member and my faculty for giving me this platform to present a case. So the case history. 33 years old male resident of Dharavi came with the chief complaint of swelling, redness, watering in both eyes since 2 months. Patient was apparently alright 13 years back when he noticed prominence of both eyes, which was insidious in onset, gradually progressive in nature to reach current status. Patient also complaining of swelling, redness, watering in both eyes since 2 months. There was no history of discharge, pain, fever, diminution of vision, diplopia, trauma and ocular surgery, no increase in prominence on bending forward. Patient is taking some medication for thyroid disease in the morning since 13 years. Patient is a chronic smoker for many years, taking 4 or 5 cigarettes per day. Family history was not significant. On general examination, patient was oriented, conscious, vitals were within normal limit, all systemic examination were within normal limit. I would like to describe right eye first. Vision in the right eye was N6, 66 N6 and color vision was normal. Conjunctiva shows congestion. Cornea, anterior chamber, iris, pupil and lens were within normal limit. Intraocular pressure with short tonometry in primary gaze was 17.3 and in upgaze was 24.4 millimeter of mercury. Sherman test and fundus were within normal limit. In left eye, vision was 66 N6 and color vision within normal limit. Conjunctiva shows congestion. Cornea, anterior chamber, iris, pupil, lens were within normal limit. Intraocular pressure in primary case was 17.3 and in a case it was 20.6 millimeter of mercury. Schirmer test and fundus were within normal limit. On examination, head posture was erect. There was no facial asymmetry. Extraocular muscle were restricted on abduction, adduction, and in up gaze. There was bilateral axial proptosis with superior sulcus fullness and lower lid retraction. Inferior sclera show in the right eye was 4 mm and in the left eye was 3 mm with lag off of 2 mm with good Bell's phenomenon. Increased retrobulbar resistance on retropulsion test. There was no palpable mass, tenderness, erythema, no increase in proptosis on bending forward, no Bruyne auscultation and no palpable thrill noted. On Herthel's exophthalmometry, at the base of 106, right eye was 26 millimeter and left eye was 24 millimeter. Palpebral fissure height in the both eye was 15 millimeter. Positive signs in this patient was Inros, Vigorex, Stelbeck, Ballet, Goldziher and Sattler signs were present. On clinical activity score, there was eyelid swelling, conjunctival injection due to the acute disease, inflammation of caruncle, increase in 2 mm in the proptosis, decrease in the uniocular excursion. So the total score was 5 out of 10, suggesting acute disease. There was no visual impairment. Inflammatory score was 3 out of 10. Strabismus score was 1 out of 3. 3. Appearance was moderate. So based on the clinical history, an examination, the provisional diagnosis is bilateral axial proptosis with moderate thyroid eye disease. The patient on investigation, patient is euthyroid. There is increased thyrotropin receptor antibodies. Thank you.
Thank you, Dr. Novera. Very well presented. I invite Dr. Shruti for her comments and questions to the PG.
Yeah, thank you. Nice presentation, Numudra. Nicely described. So, in your presentation, you are saying it is a moderate thyroid eye disease, right? So, what exactly is the active thyroid eye disease?
In the active thyroid eye disease, there is soft tissue involvement. So there can be periorbital edema, erythema, chemosis, congestion, orbital infiltration. There can be lid retraction, proptosis, or diplopia. And it is followed by the inactive fibrotic stage, where you can see orbital fibrosis and enlarged extraocular muscles.
Okay. So, and since your patient had bilateral proptosis,
Yes,
are there any cases where you see unilateral proptosis in adults? What could be the differential diagnosis?
The most commonly it is seen in thyroid eye disease. Others can be the orbital
bilateral. Yeah.
It can be seen in orbital cellulitis, non-specific orbital inflammatory disease, in inflammatory tumor like lymphoma, and it can be in osteotoma.
It can be seen in orbital hemangiomas, then malignant lymphomas, can be seen in optic nerve gliomas, or any other lacrimal gland tumors. Okay.
Yeah, it can be seen.
Yeah. And what is the role of steroids in thyroid eye disease?
Thyroid eye disease is an autoimmune disease, so it's
Can you
We have lost her
hear? Because I think there is some internet problem with.
at her end.
Connection is.
Yeah. Dr. Nuvaira, I think that there was some internet connection problem from your
Yes.
side. Yeah, so like, can you just repeat your answer?
Thyroid eye disease is an autoimmune disease. So the steroids
Right.
are given to reduce the inflammation. So there can be a reduction in orbital chemosis, erythema, congestion can be seen uh, within 48 hours, and full response can be seen within 2 to 8 weeks.
Right. So is there any other indication of steroids, like in vision threatening conditions, like in
Yeah,
optic
it is used in
neuropathies?
optic neuropathy
Yeah.
also, and in
Yeah.
active thyroid eyes.
So what is the dose generally we give to the patient?
In moderate to severe eye disease, 0.5 gram given for 3 days. The cumulative days should not be more than 8 grams. It is followed by 0.25 gram for 3 days.
Followed by oral prednisone can be given.
Followed by oral prednisolone. 100 gram given and 100 milligram given and 10 milligram tapering for almost around 12 weeks.
Okay. And for chronic diseases, a pulse therapy of steroids also can be given.
Yes.
Yeah. So for thyroid eye diseases, we generally advise patients for imaging. So what are the signs we look for in thyroid eye diseases on imaging, especially for extraocular muscles?
The CT orbit shows very characteristic finding like sparing of tendon with muscle belly enlargement. There can be orbital fat expansion, and on MRI we can also assess the water content of extraocular muscle, which reflects the disease activity. On CT scan, we can also assess the crowding of optic nerve at orbital apex.
Right. So basically, it differentiates thyroid myopathy from. If the tendon is involved, then what is the most likely diagnosis?
Myositis, ma'am. If the tendon is involved.
Yeah. So, and what are the commonest muscles which are involved in thyroid eye disease?
Inferior rectus is most commonly involved because it is a active muscle and it has good septal connection with the adjacent periorbit, and it is followed by medial rectus, superior rectus, then lateral rectus.
Right. Very good. So, in association with thyroid eye disease, there is often lid retraction, which was present in your patient. So, what are the common causes of upper eyelid retraction?
There can be the molar muscle overactivity due to the increased sympathetic overstimulation. It can be because of the fibrosis of LPS and SR complex in later stages, and it can be because of the entrapment of the inferior rectus muscle.
Right. So, and what are the causes of lid lag in thyroid eye disease?
Mostly it is because of the Ptosis, but it can be because of the LPS muscle edema, thickening, and fibrosis in later stages.
Right. So, suppose in patient requires a surgical management in thyroid eye disease because of severe proptosis and orbital decompression, which is most commonly preferred if it is required. But suppose the patient is also associated, has strabismus and eyelid retraction. So, what is the preference? What is the order in which we should treat the patient? What should be dealt first?
It should be orbital decompression first, followed by squint surgery, then followed by lid reconstruction surgery.
Okay, good. That's correct. But why is it so?
because it can alter the deviation of squint or lid retraction. So to get desired result, these sequences.
Yeah. So once the orbital decompression is the strabismus and retraction or may reduce on its own. So firstly, the orbit should be drilled first. Sir, would you like to add anything or ask anything, ma'am, Dr. Maya?
Yeah. Very well presented, very meticulous examination. You have calculated the clinical activity score also, visa score also, and you have answered all the questions so well. So I'm very much impressed that being a postgraduate, your knowledge about thyroid ophthalmopathy is so in depth. A few things that I would like to add that one thing is that you mentioned the Shermer's test fundus in your examination within normal limit. So whenever you're presenting in exam, you should mention the values. Okay, don't write within normal limit. Okay, so if Shermer's ka aapka value 2 or 3, whatever it was, you have to mention that. And then you know that optic neuropathy is a very important association in clinically active thyroid disease. Okay, so in fundus also you mentioned that the disc margins were normal, there was no disc edema likewise. Okay. Then one important risk factor that you have mentioned in your history, would you like to comment upon that? What was that lifestyle risk factor that has a very strong association with thyroid ophthalmopathy that was there in your case?
Yes, ma'am. The patient is a chronic smoker, almost around 15 to 16 years, and taking 4 or 5 cigarettes per day. So,
right. How smoking is associated with the thyroid ophthalmopathy?
It will increase the release of
it is very important to ask the history of smoking, and that was positive in your case, right? So, all right. Nice presentation.
One more thing, Nuvera, in your presentation, you had checked your IOP in primary position and in the up gaze. So that is very important. But why was that?
The increase in IOP is because of the restricted muscle motility. So the restricted muscle motility will transmit the pressure on the globe.
Right.
So that's it.
No,
So
1
you are
minute.
ruling out any fibrosis of the muscle.
I'd just like to make a correction there. Can I?
Yes, sir, sure.
Yeah. When the patient is looking straight in your applanation, also the same restriction is there, correct? The inferior rectus is still holding tight. So why should there be an increase in pressure when the patient is looking up? The same tightness is there, no? So would you like to modify something now?
Increase in pressure can be because of the increased episcleral venous pressure.
No. I think that is going to be the same when the patient is looking straight and when the patient is trying to look up. See, when the patient is looking up, then your inferior rectus is anyway tight, which is tight when the patient is looking straight and in all the cases, the same amount of tightness. But when the patient is looking up, then the superior rectus also contracts, correct? So now when the patient is looking up, both muscles are contracting, so there is a pressure on the globe. So that's why you see an increase in pressure on an applanation. Okay?
Yes, sir.
Have you understood that, Beta?
Yes, sir.
Okay. And all these symptoms for a thyroid patient, which time of the day is it generally more? If that is your question, what would be your answer? All the symptoms are going to be more in the mornings. When the patient has just got up, that's when the patient is going to have all these problems. And the reason for that is venous engorgement. Inside the orbit, the veins have become engorged and all these problems become more because it's a congestive orbitopathy. Okay. So that term you should try and add into your exam. Your examiner would love to hear that. Okay. Otherwise, it was a wonderful presentation. Congratulations.
Nirav, you're there?
Yes, Sumit, I am here.
Yeah.
So
Please start the panel questions.
Yeah. So, in the case presentation that Dr. Novera just presented, the patient was euthyroid, but the thyroid antibody levels were high. So, I would like to ask the panelists that do you advise thyroid antibody tests to all suspected cases of TED or to only a specific subset?
Dr. Vidya, would you like to answer that? Okay, so I generally advise for antibody test. One thing is that in euthyroid subset of patients, definitely they provide a supportive evidence. And then other than that, it directly correlates with the disease activity because, the TSH receptors are there in the orbital fibroblast also. And the high level of antibodies, it is an objective measure of disease activity as such. So that way is also it's important.
Thank you, Dr. Maya.
I would probably do the antibody, not in the first time, but probably if there is going to be a relapse and things like that, because first time the antibodies we are not going to be looking out because most of the patients may not be having the antibodies. Antibodies, if it is there, then we are looking at Graves or Hashimoto's. That is what we generally would probably come to a diagnosis. So first few times, probably 2 visits, we may not ask for the antibodies, but when it is a return of the thyroid eye disease, then that's when probably I will ask for an antibody.
Right. Thank you, sir. So the next question is that if the CAS or the clinical activity score is less than 4, suggesting an inactive thyroid eye disease, but the patient presents with diplopia. So what would be the next step? Would you still start immunosuppression or steroid in such cases? And what would be the dosing schedule or regimen?
Yes, so clinical activity score is less than 4, but patient is having diplopia. So diplopia itself put the patient into a category of moderate to severe grade as per UGOGO. And in the moderate to severe grade of UGOGO, it is advisable to start on steroids. And my preferred regime is IV MPS, and I follow the weekly 500 mg protocol. So I give 500 mg IV MPS till 6 weeks, and after that I reduce it to 250 mg every week, total of 12 doses of IV MPS. So that is my preferred regime for cases of diplopia, and I would also like to do an imaging to check for the muscle thickness, and if the muscle thickness is reduced at the end of the IV MP regime, then I will wait that the disease remain inactive for 4 to 6 months, and then probably I would like to intervene with any kind of squint surgery if patient still have persistent, kind of motility restriction or diplopia. Usually, in my experience, the diplopia, it gets improved with IV MPS alone in most of the cases.
Thank you, Dr. Maya. So in such, what I draw conclusion is that even when the disease is inactive, but the patient is presenting with diplopia, you would take it as active and the regimen would be same, like how we treat an active thyroid eye disease. The 12 doses are same for the active as well, right? Active patients, right?
Yes.
Right. And would you give any importance to the radiological activity like T2 hyperintensities in the muscles? Would you give any importance to that in terms of follow-up or modifying the regimen?
I usually see, definitely on the stir sequence, it's important to see the hyperintensities. But yes, I give more importance to the belly thickness of the muscle because we don't want to operate or touch upon the muscle which is still inflamed or thickened. So definitely both of the parameters are important, the thickness as well as the hyperintensities on stir sequence.
Thank you, ma'am. Dr. Vidyashankar sir, your inputs, please.
I would follow the same as what Dr. Maya has mentioned, because if the diplopia would mean that it is an active disease. My thing is probably if in your hands giving a depot would in at least in patients where there is going to be a diabetic or a bad diabetic in such cases, then probably a depot will also help for taking away the inflammation and preventing that much amount of a diplopia. Uh, After IVMP, the diplopia does come down significantly, probably no diplopia, and the rest of the diplopia can be taken care by giving them a little. Since I'm an optometrist, also I would probably look at a prism for horizontal diplopia in such cases. So. And if the diplopia is bad, then the best is to put a frost glass in one of the spectacles. Because finally, the patient has to benefit.
Thank you, sir. So this kind of winds up our thing about steroids in thyroid eye disease. So what is the next step for patients who are not responding to steroids, or are there any situations where you would consider non-steroidal agents or other immunosuppressives for patients with thyroid eye disease?
Yeah, definitely. If there is a suboptimal response, then perhaps we would like to add some immunomodulator. And like I said, I used to give the 500 mg IVMPS 6 doses every weekly. So at the third or fourth week itself, I would like to add any immunomodulator, most likely azathioprine or mycophenolate. That is my preferred drug that I'd like to add. And because the effect also takes some time to come, and till the sixth dose of IVMPS is finished, then the effect of immunomodulators will catch up. So I will shift to immunomodulator in such cases when the response is not complete or suboptimal with IVMPS. Or in such cases where you have already given a few shots of MPS and the cumulative is, reaching 4.5 gram, and you cannot give further steroids. In those cases also, I would like to switch upon immunomodulators.
Dr. Vidyashankar?
I would also agree to that. There are some other rituximab and all these others, tongue twisters, as I call them. So many of them also have been tried. There are some conflicting reports, but the students should be in a position to give these names as well. Okay, they are biological prepared ones. So the students should be in a position to mention the names at least. They're all immunomodulators. They come under the same.
Right. Thank you, sir. Now, in cases where there is compressive optic neuropathy and an active disease, would you prefer orbital decompression via an external orbital route or an endoscopic decompression?
I would go from what I'm more comfortable with in cases of where everything is swollen up and chances of hemorrhage and all that. Going through a more smaller axis from the nose is something which I would dread if I'm going to have a huge amount of bleeding. So I would go our time-tested orbital route only. And it's not very hard. If the students have been doing their enucleations and all that, I think going and seeing the nerve and being able to look around that is something which they will pick up once they are doing their fellowships, I guess. Dr. Maya?
Yeah, definitely. My preferred route is also orbital. But first of all, in the compressive optic neuropathy he asked. So again, I would like to give IVMPS first, for a compressive optic neuropathy because it's sight-threatening condition. And later on, once the disease is inactive, then only I would like to go for a decompression.
Thank you, ma'am. Sumit, do we have any other questions from anyone? Or
I think you can go ahead with your cases.
okay, so here for the benefit of the PGs and also for the audience, we have compiled just a couple of case scenarios, very short case scenarios, which we will be taking you through. And I would request the panelists to give their opinion.
Before that, just I want to interrupt Dr. Nirav. Dr.
Yes,
Naina
sir.
madam is there, I think. If she wants to say something, Dr. Naina Poddar madam. Dr. Naina? Okay, she is not there, I think. She's mute.
I
Okay,
think
go
so
ahead,
she is
please.
traveling. So.
Okay, please go ahead.
Yes. So is my screen visible?
Yes.
Right. Just 1 second. So now all of us are aware that we cannot perform cataract surgery in a case with existing nasolacrimal duct obstruction, but there are several practical situations. Also, there are several papers which tell us that the normalization of conjunctival flora after a successful DCR takes about 3 to 4 weeks. So let us take a few case scenarios here. So this is case scenario 1, a 68-year-old male patient with mature or hypermature cataract presents with complaints of diminution of vision, watering and discharge. On clinical examination, there is frank choroplast positive, suggesting chronic dacryocystitis. So what are the options we have here? We have two options here. We do a dacryocystorhinostomy followed by 4 weeks of waiting time and then do the cataract surgery, or we perform a dacryocystectomy and do an early cataract surgery. Can the panelists please share their opinion regarding this?
Yeah, that's a very, very tricky situation that you have given. So I definitely do not prefer DCT, and I would go for a DCR surgery, and but rather to wait for 4 weeks in such a hypermature, which is like going to burst out and give a faculatic glaucoma in few weeks. So at 2 to 3 weeks, you can send a conjunctival swab perhaps, and then under antibiotic coverage, you can go ahead with cataract surgery.
Correct. Yeah, probably a practical way to approach this situation.
Right.
Sir, would you do something different or?
No, I would do 2 swabs. First, start the patient on an antibiotic. Take the first swab, same day probably when you have prescribed. Take the second swab after a week. Look at it, because after the first swab, I will know the organism. I will also do the culture sensitivity. If there is going to be a difference in the culture sensitivity, then I would probably change my antibiotic, call up the patient, change the antibiotic and things like that. In all of this, the patient has to be told that what he is going through. Despite all of this, there is a chance of infection, and that chance of infection is there in any case. And the patient has to be told the situation, and the patient has to agree to the cataract surgery. I see quite a few cases where just the cataract is done where there is a frank choroplast as well. So these are some things that we need to be avoiding. And 2 swabs are generally recommended, because if the first one is you have started, the second one you have confirmed that there is nothing else, and you have had a chance of changing the antibiotic according to the CS. Medico-legally will be.
Right. So this swab you'll be taking after you perform the DCR, right?
These, even if you are not going to be doing a DC, even if it is going to be a CCB, where you don't have an LDO, but you have a CCB, in such cases also it's better to do a swab and only then operate.
Right. Correct. Thank you, sir. That probably answers
one question I would like to ask over here. If you have done a DCR with a stent, are we justified in doing the surgery of cataract surgery with the stent in position? Yes, very much. We can do it with a stent. The same thing is we do a swab. And when doing a swab, we be careful of not pulling the stent out from the canaliculus.
Sir, here I would like to add a question. Dr. Santosh sir is here. Santosh sir,
yes.
You look after both anterior and the posterior segment cases. So, in your vast experience, how many cases of endophthalmitis you have seen where the primary surgeon has missed the dacrocystitis and operated on some as an intraocular surgery and then landed up in an endoff?
No, actually, most of our surgeons are very well aware of all this situation. Without DCR, I think no surgeon will opt for cataract surgery. So that's why I didn't see any endophthalmitis because most of the surgeons, they go for DCR first. So I don't think, but it's very highly likely chances that if you miss that, then you would have endophthalmitis. There is a high risk because there is a frank conjunctival flora will be there, bacterial flora. So you should not operate that cases.
Thank you, sir. Neerav, you can go ahead with the next.
Yeah. So Sumit, here another question that arises is that for pre-op cataract evaluation, is Roplas good enough or we do syringing for all cases? So any thoughts on that from the panel?
I think Roplas is a basic test that should not be missed. If the patient is not symptomatic for watering in your OPD, he has came for diminution of vision and he wants to go ahead with the cataract surgery. And I don't think that there is any need for syringing in all pre-op cases unnecessarily if the Roplas is negative and patient is asymptomatic for watering. If the Roplas is negative, patient is symptomatic for watering, even if it is intermittent, then definitely you should go for syringing.
Thank you, Dr. Maya. So now let's take case scenario 2. This is a 70-year-old male with significant cataract in both eyes. The patient's primary complaint is diminution of vision. He does not complain of discharge nor any significant watering. On syringing, there is immediate clear regurgitation from opposite punctum and a soft stop on probing. So what are the options we have here? The options are DCR followed by cataract surgery versus cataract surgery directly. Dr. Vidyashankar sir, would you like to take this question?
If the patient is not complaining of watering, then I would not think of going ahead with the DCR. What are we going to, other than for giving a so-called scar and a little less bone in the nose? I don't think we are achieving anything. The patient will come back and say that pehle bhi nahi tha, now also I don't have watering. So what have we basically? So there has to be a surgical reason for going ahead with the DCR. So in my hands, I would not do a DCR. I would directly, if the thing is not patent, like I said in my previous is also, do a conjunctival swab. If everything is okay, go ahead with the cataract. But yes, if the patient complains of watering, then yes, DCR. Madam?
Dr. Maya, would you like to add something?
Just now we discussed this thing only, that if the patient is not complaining of watering, then there is no point of doing surgery. Because probably the other punctum, the upper canalicular system, it is patent, and that's why he is not having watering. And there is a soft stop through one canaliculus. So, or there can be a, sometimes on syringing probing also, there sometimes, if the method is not correct, you get a soft stop. Most of the times postgraduates do it. And if they're not in correct direction, then they can hit the wall of the canaliculus, they can get soft stop. So if the patient is not symptomatic, the basic thing is that you don't have to operate upon that. Mhm.
Okay, so now we move from dacrylology to ocular surface. So a 47-year-old female presents with a history of mass near the temporal limbus since last 1 year. On examination, there is a mass with surface keratinization, feeder vessels, and internal vascularity over the bulbar conjunctiva. So out of these options, what would the panel do in their experience? Is it excision with cryo with MMG or excision combined with topical chemo, or an impression cytology or some form of biopsy and then decide, or go for direct topical chemotherapy with interferon or mitomycin, or use intralesional injection chemotherapy? So you're basically, we are probably looking at a very typical presentation where probably our clinical judgment says that this is ocular surface squamous neoplasia. Then what is the preferred practice?
If we are looking at, sorry, go ahead, Dr. Maya.
Okay, so I think it's very well defined, very localized, and very amenable for excision. And at the same time, it's quite very much amenable for response to topical interferon as well. But still, in my sort of practice, the patients are mostly coming from remote areas and they may not follow up well after giving topical chemo or interferon. So I usually do to go ahead with primary excision in these sort of cases in my practice.
I would also go for a primary excision. There is no justification of giving chemo without a histopathological guide. Even if we find clinically also that is extremely 99% is going to be ocular squamous neoplasia, I think justification of putting the patient to chemo, at least in my hands, I don't feel it justified. So I would, and it is very well circumscribed. So I would probably excise this completely. I would not even put a primary this cryo over there. I would just excise it, cover it with an AMG, and if something comes back, then yes, I would probably and I would have explained it to the patient first itself that if it's going to be coming out as something ominous, then I would probably have to retake him up for surgery.
So usually after excision of OSSN, is it in your practice, is it a norm to give topical chemo or topical immunotherapy in post-op period? I usually do not prescribe.
No, not in post-op period.
Yeah, because in the second option they have.
It will not come back.
So I think first is correct in my practice.
So in case the margins come positive, or there is something that tells us that probably the excision was not complete, then would you go ahead and further excise, or you would cover that up with a chemo? Topical way.
Of course, then see, usually in all such cases, we have to do it with no touch technique. We have to have a clearly, clean 4 mm margin of the conjunctiva. We should not have a margin positive, but still, if it comes positive, then you have to start on topical immunotherapy with interferon or topical chemotherapy, either of the two. Mm-hmm.
And they do very well. The patients respond, the whole thing melts. Melts means the tumor melts.
Right. Thank you, Dr. Vidyashankar. Thank you, Dr. Maya. I thank both the mentors and both the PGs. Dr. Sumit, are you still there?
Yeah, very much. So, Atul sir, are you here? I think he's occupied. You can stop sharing, Nirav.
Yeah.
So, I would like to thank Dr. Maya ma'am, Vidya Shankar sir, Shruti ma'am, Naina ma'am, Nirav, and both are main presenters for today, Dr. Noera and Dr. Arya. Thank you so much for being here. Maya ma'am, Vidya Shankar sir, any last closing remarks from you for the betterment of a program or anything that we can do better for the PG activities in this webinar?
I think MOS is doing a great work, and I'm thankful to Dr. Santosh, Dr. Vardhaman, and Dr. Sumit, and Dr. Nirav, Dr. Aditi, everyone for this for conducting this so well formulated PG teaching program and covering every specialty. And I congratulate you all. Very wonderfully organized.
I would second that.
Thank
I
you,
would
ma'am.
second.
Dr. Vidya Shankar, please, sir. Any modification you want in our program?
You're doing such fantastic work, sir. It is sometimes too good to be true. So
Thank you.
it's really very, very well conducted. And I'm quite sure that the students would be very, very benefited in this. Congratulations.
I
Thank
think
you. It's all.
in the PG presentation, they can include diagrams also, like fundus like not in these cases of oculoplasty, but in cornea, retina, other case presentations, they can include diagram for the benefit of other postgraduates. Handmade, like retina chart or fundus chart or corneal diagrams, likewise.
That's a good idea.
Surely, ma'am. For retina program, we'll remember that and we'll implement as well.
Dr. Shruti, Dr. Naina, anybody wants to give comments for PG presentation and improvement?
Yes, sir. Actually, they have been very good with it. I know with their busy schedule and all, like OPD days and all, but it has been good. And thanks to MOS and to you, sir, for organizing such PG presentations, so that in their final exams they will improve.
It just
Yes,
all
I agree
because
with
of
Shruti.
Dr. Yeah, Naina, please.
Naina here.
Welcome.
Yeah, hi.
Hi.
Yeah. I'm on and off. I'm traveling. Sorry for it. Yeah,
Okay.
I agree with what Shruti was saying, and it gives them a good platform, a new confidence. And
Yes.
so, whatever mistakes can be done will be done here. Corrections will be done here. It's a wonderful initiative. Keep it up. Thank you.
Thank you, Naina. Thank you, Shruti, madam. Atul, Mandar, anybody is there? Atul, your comment, please. Atul is, I think.
Yes, I think sir is occupied. I tried messaging him. So
Yeah.
we'll thank
Okay.
on behalf of MOS everyone. And we will meet you again with the next Oculoplastic program after 2 weeks. Thank you so much all for being here.
Thank you.
Thank you. Thank you and good night, everyone.
Thank you, everyone. Good
Thank
night,
you so
everyone.
much.
Thank you.
Good night.
Great. Good
Good
night.
night.